I'm Allon Barsam. I'm a consultant eye surgeon. I specialise in cornea, cataract and refractive surgery. My practice at the moment is split between a National Health Service practice which specialises in complex corneal problems and lens-based problems such as corneal transplant and lens problems such as wobbly lenses or iris repair, as well as sometimes complications of refractive surgery. My private practice is predominantly vision correction surgery with cataract surgery, often using premium lenses. In 2018, there are an enormous array of refractive surgical options. There's a lot more that we can offer patients today. The technology allows us to do this in a much safer way, but it can be really confusing for optometrists and ophthalmologists to know what is available for patients and which patients may benefit from the different treatments. What we're going to try and go through today are the various options available. We'll try and talk about the risks, the benefits, what's involved, so that you feel well informed in terms of explaining to your patients what's out there and what can be done. The main options for refractive surgery today are broadly split into laser vision correction options and lens-based options. The laser-based options, the one that is most commonly used and the most popular technique is LASIK. Other options for laser vision correction involve surface procedures such as LASEK, PRK, which stands for photorefractive keratectomy, and alternatives are epi-LASEK and PTK, which is a therapeutic version for surface of cornea disease. The other laser vision correction options involve SMILE, which is basically a lenticule. Lenticule is created in the cornea, and no excimer laser involved in the procedure. As far as lens-based options, the main two are what I consider additive lens options, so phakic intraocular lenses such as the implantable Collamer lens or the implantable contact lens, and then intraocular lens replacement, either in the form of refractive lens exchange or cataract surgery, depending on the status of the patient. And there are a variety of different lens options involved in each one. So for LASIK, we use two lasers with modern technology. We use a femtosecond laser to create a customized flap in the surface of the cornea, and then we use an excimer laser to reshape the cornea depending on the patient's prescription. The surface procedures don't involve a femtosecond laser. They involve some way of removing the epithelium, either manually or with a laser, and then the excimer laser will reshape directly under the epithelium. Patients then need to heal with re-epithelialization. And one of the reasons that the surface procedures are less popular and less commonly performed is that recovery is painful and it's a slower process to achieve the best vision. The SMILE procedure involves only one laser, which is a femtosecond laser, which creates a lenticule within the cornea in order to reshape the cornea. This is a newer procedure, and we're still evaluating the safety and long-term data to try and decide how useful this technique is. For refractive lens exchange and cataract surgery with premium lenses, there are a variety of different lenses available. Patients can be treated for just distance vision. If they have astigmatism, they can be treated with toric intraocular lenses. They can be treated with multifocal or trifocal lenses, which have focal points at various working distances depending on what the patient's requirements are. And there are also extended depth of focus lenses, which are supposed to simulate natural vision more than the more old-fashioned form of multifocal lenses. The main reason that people seek out refractive surgery is in order to be independent of glasses or contact lenses. Although the majority of people are very happy with glasses and contact lenses, and the majority of patients that optometrists will see have no problems with their glasses and contact lenses, there are a percentage of these patients who, for whatever reason, don't get on well with contact lenses or glasses. For glasses, people sometimes find it limiting in terms of the activities that they want to do. If people do, let's say, outdoor sports, if the weather isn't good, if it's raining, they can have problems with their visibility through glasses. And also, depending on their prescription, the glasses can induce visual distortion sometimes, either barrel distortion or prismatic effect, where they feel like they're losing objects as they come in and out of their field of vision. Presbyopic patients often are particularly miserable with glasses on account of the fact that they may need more than one pair. If they can't tolerate varifocal or bifocal glasses, then they may need a separate pair for distance, a separate pair for close work, and sometimes even a separate pair for intermediate work, depending on what they do. For patients that don't wear glasses, they can try contact lenses, and many patients have no problem with contact lenses and they wear them safely and comfortably. But again, there's a small percentage of patients who don't get on with contact lenses, either because they can't wear them comfortably, or because it may exacerbate ocular surface disease, or because again they just find the reliance on them or the inconvenience associated with having to put them in, clean them, take them out, a problem for their own lifestyle. So essentially it is a lifestyle choice for a patient to not want to wear glasses and contact lenses, because the technology has evolved quite rapidly and the ability that we have to treat various prescriptions has come on leaps and bounds really in the last 2 decades. People are seeking it out with increasing frequency. So there's quite a lot of mythology that I think is outdated and maybe historical that exists within both optometric and ophthalmic communities about which element of refractive error can be treated with refractive surgery. And the answer is that there is no refractive error that precludes the option of refractive surgery. It may not be the same intervention for every single degree of refractive error, but every single potential refractive error could be treated with refractive surgery. Having said that, there are various things that will exclude a given patient from different options, and it may be that there is no option available to a certain patient, but it won't be the prescription alone that dictates that. It's other safety factors and anatomical factors that are specific to that patient's eye, that are specific to the prescription that we're trying to treat, and that are specific to the intervention that we think will be best for that given refractive error. So we can treat myopia, hyperopia, presbyopia, and astigmatism, and often a combination of those, with many of the refractive surgery options available. The main issue with nystagmus is that the patient's correctable vision is often reduced. We all have our own thresholds for amblyopia, for example, but I prefer not to do refractive surgery and certainly laser vision correction surgery on a patient with significant amblyopia, because it can make it difficult to chart the outcome afterwards to know is their vision limited on account of a pre-existing problem or not. But also, if they have, let's say, one eye that is significantly amblyopic and one eye that isn't, then I feel that it doubles the chance of having a significant adverse event, which I'm uncomfortable with. So if a patient has vision of 6/18 or worse in the amblyopic or worse affected eye, then I will essentially exclude them from laser vision correction. For nystagmus patients, they often have bilateral poor vision, and the nystagmus itself is not a contraindication, but they often don't seek out refractive surgery because they may require some prism in their glasses as well to try and reduce the amplitude of their nystagmus, and we can't overcome the need for a prism in glasses with laser vision correction. All we can do is correct the refractive error. Broadly speaking, for laser vision correction, we rarely will treat more than -10 diopters of myopia. The exception to that would be a patient that has a thicker than average cornea and patients that have a smaller than average pupil in nighttime vision conditions. So it allows us to give a more conservative laser ablation for that degree of refractive error. In terms of hyperopia, we can treat up to +6 diopters of hyperopia, but once we are treating significantly above 4 diopters of hyperopia, we know that regression, i.e. some loss of effect with time, becomes more likely. So again, it depends on the age of the patient and whether other options may be available. For astigmatism, we can treat up to 6 diopters of astigmatism with a laser, and if there's more astigmatism than this, we sometimes have the option of debulking or reducing the astigmatism with incisional techniques, and could then offer a patient laser vision correction once they have less than 6 diopters of astigmatism. In terms of presbyopia, the decision-making process is very much along the lines of what is it this individual patient wants and needs. Some presbyopes are really happy to just have their distance vision corrected and wear glasses for reading. Others do not want to undergo any refractive surgery unless they have a near guarantee of not requiring glasses for anything, and it very much depends on what patients want. In general, the more they want in terms of complete independence of glasses for all activities, the more they need to accept some form of compromise in the quality of their vision. And normally the patient's decision is, would they rather have some compromise in the quality of their vision or a compromise in their lifestyle, which means being dependent on glasses for the various activities that they require. There is also the option of bioptics. which essentially is combining more than one kind of intervention. So an example would be for a patient that has extremely high myopia, such as -24, phakic intraocular lenses tend to only go up to about -20. So we may put a -20 implantable Collamer lens or implantable contact lens in, and we could then do LASIK for the residual refractive error. Another example is if we were treating high astigmatism and a patient would be a better candidate for refractive lens exchange, they may want a trifocal lens where treating high astigmatism can be problematic. In those patients, providing the ocular surface is good enough, we could potentially eliminate their astigmatism with laser vision correction, normalise their cornea, and then implant a trifocal lens as part of refractive lens exchange so that they're benefiting from the best of all technologies in order to have the vision that they want and require, and we call that bioptics. For laser vision correction presbyopes, we normally will assess them for their suitability for a monovision type scenario, which is often called laser blended vision. But essentially we are treating and targeting the dominant eye for emmetropia or infinity distance vision, and the non-dominant eye we're deliberately either leaving some myopia or driving some myopia into this eye in order to allow them to have a nearer focal point. And then the two eyes work well together, they learn to adapt and adjust to this, but that's not a completely permanent option for small print reading for all prescriptions. It very much depends on what their individual prescription is and how far into the presbyopic age range they are. So there are various ways of assessing ocular dominance. The reality is there are some patients that are genuinely cross-dominant, so they don't actually have a dominant eye. And so I think some of the confusion about is the test good or are people using the right ocular dominance test stems from the fact that some patients will just not favour one particular eye, so the testing is often ambiguous or inconclusive. And in those patients, sometimes the blur test can be useful, which is essentially giving the patient a +1 lens, and they should prefer that over their non-dominant eye in theory. So which setup they prefer, dominant eye perfectly corrected for distance and non-dominant eye +1 blurred, is one way of checking. What we like to do is essentially line of sight. So we ask the patient to create a small hole within their hands and then fixating on the eye of the examiner to bring it up to their face and then see which eye they will target by doing that. If they come exactly in between the two eyes, they're cross-dominant, but often they will favour one eye. And then if we're not sure or we want confirmation, we can ask the patients to point. They can point in the middle of a Logmar or Snellen O, and then they close the eye, and it's the dominant eye that will be essentially fixating, so you can work it out. When they tell you whether the image moves or not, then you know. In terms of deciding whether a patient will or won't tolerate laser blended vision or monovision, we have a variety of tests and techniques that we use. What we like is actually a loose lens test, so we will present +1 over the non-dominant eye and gauge their reaction in terms of how uncomfortable they find this. The problem with a contact lens trial is that in order to adapt and adjust to laser blended vision, it takes 6 to 12 weeks of neuroadaptation. So it takes a patient 6 to 12 weeks to feel completely comfortable with their setup. And patients who by definition are not happy wearing contact lenses, which is why they've come for a laser vision correction evaluation, will generally not give you 6 to 12 weeks wearing lenses in order for you to decide if it is or isn't a good option for them. So that's one consideration. The other thing is that laser vision correction will induce positive spherical aberration. So this is a higher order aberration that we can measure on our wavefront aberrometry tests, but is imperceptible to a patient. So it doesn't interfere with the patient's quality of vision, but what it does do is it increases depth of focus. So it means that the two eyes work more comfortably together having had laser vision correction than would be the case with a contact lens, because the contact lenses don't induce those kind of aberrations. So they don't have the same depth of focus, the same blend, the same way that the eyes work together when they wear a contact lens as to when they are having laser vision correction. Having said that, if a patient comes to us with a history of having tolerated the vision associated with monovision in contact lenses, then we feel very comfortable that we can and should replicate that with the vision that we choose for them. There are some exceptions. So if patients have very visually demanding jobs and are, for example, emmetropic, where we would feel potentially nervous about compromising the quality of vision through a monovision scenario. An example would be a surgeon who is an emmetrope, who is presbyopic. We might feel uncomfortable about deliberately making one of the eyes, let's say minus 1.50 or minus 1.75 spherical equivalent, not knowing if that would interfere with surgery or other day-to-day activities. So in these patients, we tell them that they won't necessarily be comfortable with contact lens, but we just want to know that they can function. Can they actually manage to do the things that they need to do? Do they have the vision that they need? And we will occasionally pursue that, but it's not something that we do routinely because we find that it's patients comply very poorly with it, so it just doesn't, you want it to happen and it just doesn't happen, and then it's often non-informative because they don't try long enough and it doesn't also simulate laser vision correction accurately enough. We do have our optometrists carry out a full ocular motility evaluation, and this is particularly important in patients where we're considering blended vision or monovision because we need to know that the eyes can actually work and function together. So we will again exclude patients from laser blended vision if they are not completely binocular. Evaluation for laser vision correction is and should be rigorous. We don't expect optometric referrers to have made the decision or the evaluation for us. It's up to us as surgeons to ensure that we screen patients appropriately and only recommend treatments where and when it's appropriate. We look at a variety of things. So we will do a refraction both in the dry state and in the wet state, so that's with some form of cycloplegia, in order to see if we can unmask any additional focusing power and to ensure that patients aren't over-accommodating, so we know that our target for surgery will be genuine. This is most relevant in young hyperopes. Some young hyperopes come to us with a presumed prescription of +1 or +2, and then once you cycloplegia, then maybe +6 or more, and we obviously have to know what we're trying to target with our treatment in these patients. The ocular surface evaluation is really critical. We don't expect patients to have a perfect ocular surface when they come to us because many of these patients, as we've said, are not tolerant of contact lenses. What we're trying to understand is, do they have a pervasive problem with their own tear production, or are their eyes dry or irritated or red or bothersome on account of contact lens wear? And finally, do they have a reversible or treatable cause of a dry or irritated ocular surface? So the most common cause of that being meibomian gland dysfunction. What we tend to do is we tend to look at the tear breakup time, which is the time it takes for fluorescein on the tear film to evaporate, and we do that before and after expression of meibomian secretions. So it gives us an idea of if we were to treat the meibomian gland dysfunction, would a patient still have dry eye or not? And in some patients we will actually instigate a course of treatment and then bring them back and then re-evaluate them before proceeding with treatment. We also need to look very rigorously at the anatomy of this individual's patient's eye. We need to look at the corneal shape and the corneal thickness. If the patient has a significant amount of corneal irregularity, then we feel there is a chance that laser vision correction may result in instability of the cornea long term, that we don't offer laser vision correction. If the cornea is too thin, again, we don't offer laser vision correction. So the patient has to have essentially a normal cornea, and how rigorous we are at defining normality will vary depending on the prescription we're treating. We're more relaxed with a -2 treatment than we are with a -10 treatment, for example, and we take all of these things into account. The patient also has a total ocular examination, which includes intraocular pressure testing, disc measurement, macular testing, peripheral retina testing. So we look at everything and the lens as well to check that that's clear and there's no early cataract or anything of that nature. So we look at everything really to check that the eye is normal, but in my opinion, the very critical thing is the refraction, dry and wet, the corneal anatomy, and the ocular surface. Those are the really main things that we look at in detail. Risks associated with laser vision correction. The main risk is the risk of ectasia, which is inducing or at least the most serious risk is the risk of ectasia, which is the risk of inducing some form of weakness in the cornea, which behaves very similarly to keratoconus. So it's essentially like the risk of accelerating or potentially giving someone keratoconus. That's estimated to affect about 1 in 10,000 eyes that are treated. We feel now we have very rigorous criteria for what is and isn't a safe treatment to do. And that depends on the magnitude of the treatment that we're trying to achieve. So the bigger the prescription, the more rigorous we need to be with all of our other safety criteria. Other factors are patient's age, gender, any family history of keratoconus, any irregularity or anything that's not completely normal with the corneal anatomy, and what's called residual stromal bed, which is the amount of cornea that essentially will be completely unaltered and unaffected from the treatment. And these techniques and criteria are being evaluated and changed all the time. So now what's of most interest to people researching this field is which kind of patients, despite having been selected on all of the established safety criteria, still go on to develop ectasia, because the assumption is most people know what the established safety criteria are and should be applying them. We do have a slightly more detailed evaluation, so we like to look at corneal epithelium as well as all of the other things, so we know independently what is happening in a patient's stroma, because epithelial changes can sometimes mask or highlight stroma structural problems within the cornea, so that's something else that we look at as well. High definition OCT would allow us to actually map the corneal epithelium, and that's something that we do. Other risks sometimes are unique to the actual type of laser vision correction being carried out. So, for example, infection is incredibly low in LASIK, but slightly higher in a surface procedure, because there's a 3 to 5 day period where reepithelialization needs to happen, and during that time organisms can gain access to the corneal stroma. Whereas with LASIK, the small gutter around the edge of the flap is healed within a few hours. So there isn't much time with which organisms can gain access to the stroma and cause an infection. Inflammation is very rare with modern lasers. We used to see it with the older femtosecond lasers, as more energy was required in order to achieve the flaps that we now use. Now they can be done with very low energy settings, and so inflammation is incredibly rare. We normally tell patients it's about a 1 in 1,000 chance of having inflammation or infection, depending on which procedure they're having, and if it were to arise, it can normally be easily treated with drops. Now, one of the things I remind patients about, some of them are worried about complete permanent blindness, but the reality is that even in the incredibly unlikely event that a patient was to develop ectasia, for example, it can still be treated. Now we have cross-linking. In very extreme cases, even corneal transplantation is an option. But for most of us, that we have very rigorous safety criteria, we haven't seen ectasia in our practice. Other complications are the chance of needing to have an enhancement. And this does vary from practitioner to practitioner. It varies depending on which kind of laser technology we're using and also the prescription that we're trying to treat. But for regular prescriptions, which is anything between -6 and +2 and up to 2 diopters of astigmatism, we quote a 1% enhancement rate. So the chance of a patient's vision being worse than 6/6 or 20/20 and then being symptomatic and bothered by the vision not being as good as they had expected it to be is 1%, in which case doing an enhancement is an inconvenience but not a major problem for that patient. As we go up to bigger levels of ametropia, so as we go up to -10 of myopia or +6 of hyperopia or +6 of astigmatism, the chance of an enhancement increases, but it rarely is more than 5 or 6% in our hands, even in the really complex prescriptions. There are various ways of doing enhancements. If the primary procedure is LASIK, and the patient is presenting for an enhancement within 2 years, then we prefer to do what's called a flap lift enhancement. So we can surgically identify where the flap was, and we can lift the flap and then put more excimer laser down on the bed. Normally it's a very small prescription being treated. So for example, if the original prescription was -8 and a patient comes back, or they end up with, let's say, -0.75, that can be enough to be the difference between really sharp vision and the vision not being as good as they want. We then do another -0.75 diopters of excimer laser, and then they're often where they should be. If the patient comes after 2 years, we will often opt for a surface procedure, because lifting the flap beyond 2 years can create potentially other problems that we don't think that could potentially be unsafe. So it depends on how quickly the patient has to be back at work and they tolerate the recovery time. But after 2 years, we normally will elect for a surface procedure rather than a flap lift enhancement. The risk of dryness is something that we always discuss with patients. So everyone's eyes get dry afterwards, normally for about 6 to 12 weeks. Sometimes patients are using drops occasionally up until 6 to 12 months after the procedure. There are lots of studies now that show that corneal innervation, which is the thing that's affected by surgery and that causes temporary dryness, is re-established fully at the 1 year time point. So we would at that time expect patients to be back to how they were before. However, we do know that patients, especially patients, for example, females in the peri or postmenopausal age range, are in the category of patients where dry eyes becomes more of an issue, and we don't want them to be having surgery around a time when they otherwise may have problems. So if they have a problem with tear production, then we do exclude them from surgery. whatever the case, we don't feel that they would recover safely, and we feel that they should explore another option for refractive surgery other than laser vision correction, such as one of the lens implant options that we've already outlined. The meibomian gland dysfunction does need to be treated prior to surgery and often afterwards, so we recommend patients take flaxseed oil. We inform and counsel them that they will need to use artificial tears frequently for the weeks that follow, but it isn't a long-term problem, with very rare exception. There's less than a 1 in 1,000 chance of a patient having to use more dry eye drops after than they did before, providing that they're well selected. Night vision problems is something that people often ask about and used to be a much more significant problem than it is now. The older-fashioned form of laser ablation, so that's the way that the laser would reshape the cornea, normally didn't respect the natural geometry and shape of the cornea. So it would essentially create a very abnormal, irregular type corneal pattern, albeit with the refractive correction required. And in low light levels, where the optical zone, i.e. the bit of the cornea that's actually working to handle light, becomes larger, that would become more of an issue. Nowadays it's incredibly rare. So with the bigger prescriptions, patients will notice some abnormality in their night vision, normally for the first few weeks, but any long-term night vision problem is exceptionally unlikely. What I like to do is a nighttime vision treatment. So the laser that I use will track the pupil, and by turning all of the lights off for the eczema laser part of the vision, the laser will essentially track the position of the pupil when it's dark, the centre of which is actually in a different location to the centre of the daytime pupil. So we deliver a nighttime vision treatment, and our night vision problems are incredibly uncommon in our practice. It's called pupil centroid shift. Essentially what happens is if you have a constricted daytime pupil here, you would assume that as the pupil moves, it does so in a completely symmetrical way, but in many people it doesn't. So it will asymmetrically dilate, which means that the centre essentially is moved. There are flap-related complications that can occur. Most of those actually manifest as a result of decisions made or potentially unpredictable things happening with the way the lasers interact with the tissue at the time of surgery. And a well-trained surgeon can normally avoid any untoward or adverse outcome for the patient by essentially aborting treatment or making a decision to revisit treatment at a later date. One of the misconceptions or things that confuse people in the public is that the industry of vision correction or refractive surgery would have people believe that the surgery is all very technology dependent, and providing people are going to a high technology centre, they can be guaranteed of safety. And although using the best technology is really important, I think the idea of a flap-related complication or some kind of perioperative complication, even if non-flap-based procedures are being used, such as surface procedures or SMILE, there are many perioperative problems that can occur if things happen in an unexpected fashion. And if you imagine that people tend to be unpredictable, the biological tissue is different in one person compared to the next, there are many examples where things can happen in an unpredictable fashion. And at that point, the surgeon has to make a decision: can they react and adapt to this unpredictable situation in order to ensure that the patient will still have a safe and predictable outcome, or is that not possible, in which case aborting surgery and revisiting at a later date normally results in no problem other than inconvenience to the patient. Other complications involve decentered ablations. One of the concerns about SMILE at the moment is that there's no way of pupil tracking. So if a patient's eye moves as the surgeon is docking, then the lenticule can be decentered without anyone necessarily knowing about it. The eczema laser will track the pupil, so if the patient's eye moves, it will either cut the laser out or it will move the treatment to ensure that it is applied over the pupil. Patients' eyes will cyclotort, or will essentially rotate when they go from the sitting position to the lying down position. Modern lasers have multi-dimensional eye trackers, which essentially will account for this and take this into account. It is important for the surgeon to ensure that the patient's head is in the anatomical position when they're lying down, but essentially otherwise any movement of the eye, any rotation of the eye or the pupil is taken into account by the laser so that we can deliver the astigmatic correction on the cornea in the correct meridian, irrespective of any torsional effect from the patient's posture. Surface treatments have their own unique risk. Recurrent corneal erosion is one of them. So that often depends on how we actually program the laser in terms of the pulses that it delivers. Small amounts of laser pulses in the form of PTK are actually a treatment for recurrent corneal erosion syndrome. So the problem tends to arise when surgeons remove too much epithelium and don't do enough laser. So providing the laser fills in the de-epithelialized areas, then recurrent erosion is very uncommon. The older-fashioned femtosecond lasers used to put a lot of energy into the eye, and one complication that used to be seen with those older-fashioned femtosecond lasers was something called transient light hypersensitivity, which essentially was patients being photophobic for a week or two after their laser vision correction procedure. This is much more uncommon now with modern lasers, and we normally give anti-inflammatory drops to try and prevent this anyway. It's worth saying that the transition from microkeratome or blade LASIK to femtosecond bladeless or laser LASIK has resulted in a significant reduction in all the kinds of flap-related complications that you could see. The problem with using the blade was that the thickness of the flap was somewhat unpredictable. Patients ended up with other problems, such as there were stories of buttonhole flaps, there could be striae or wrinkles in the flaps, and with a femtosecond laser this is much more uncommon, but is also very surgeon dependent. So in some practices there's more of this than in others. So on the day of the procedure, I like to recheck the patient's refraction again. It's another opportunity to reconfirm the measurements that we've currently taken. We also look at all of the other measurements in terms of corneal tomography, wavefront scanning, and everything else that basically gives us an idea of how we should be programming and driving the laser for that individual patient. We then go on and do the procedure. The procedure normally takes less than 10 minutes for both eyes. If patients feel nervous, we give them the opportunity of taking a Valium, which is diazepam, which is an oral relaxant to make them feel more calm. They then recover with us for about half an hour. We have a look on the slit lamp to check that everything looks as it should, and we then send them home. We ask them to keep their eyes closed for a few hours. They open them to get around, but we don't want them wandering the streets. They have to either get a taxi home or go home with someone. They can go home on the train, but they need to keep their eyes closed on the way home, and then keep their eyes closed for a few hours after that. After a few hours, the vision is normally excellent. The majority of our patients will be achieving 20/20 vision or better, and certainly by the next day that would be our expectation. So let me show you a video now of my own LASIK technique. This is another eye surgeon where I'm doing LASIK on them and narrating the procedure, so you can see the various steps that are involved in terms of creating the flap, reshaping the cornea, and all the other steps involved. It's all done under topical anaesthesia. It's completely painless. The patient experience is that they feel gentle pressure once or twice. They don't see any detail. It's essentially like, I liken it to basically looking at a light show underwater. So it's like, because we use a lot of fluid on the surface of the cornea, patients often feel like they're underwater, and there are various lights, fixation lights for them to look at and laser lights, but they don't see any detail, and patients don't describe it as unpleasant in any way. I often say to patients there are lots of legitimate reasons to not have laser vision corrections, such as being happy in contact lenses or glasses or not being able to afford the surgery, but fear of the procedure is not a legitimate reason. With appropriate instruction and reassurance, patients don't find it unpleasant at all. Patients do notice a smell. The smell is from carbon-carbon bonds being broken and released into the atmosphere. So patients often ask, is there going to be a smell of burning, or is it my flesh burning? The laser is cold, there's no collateral damage to the laser, but the eczema laser works by breaking carbon-carbon bonds. That's how the cornea is reshaped, and carbon does smell of burning. So there is carbon being vaporised essentially into the atmosphere in the immediate vicinity of the patient's eye, and I always warn them before that I tell them that they'll be smelling gas from the laser. I present my technique for advanced all-laser Z-LASIK laser eye surgery. A drop of topical anaesthetic numbs the eye, and in a matter of seconds, the Zima femtosecond laser creates a well-centered flap on the surface of the cornea. This is carried out at 110 microns of depth, and the diameter of the flap is customized to the intended zone and position of eczema ablation. The flap is then marked with ink and is gently reflected off the underlying stroma. Focus is determined, pupil tracking is initiated, and then in a matter of seconds the eczema laser ablates the cornea to reshape it in keeping with the patient's prescription. A drop of anti-inflammatory is placed in the interface, and then irrigation is carried out in the flap interface for ensuring perfect realignment with the pre-placed ink marks. A spear is then used to paint the flap and ensure perfect apposition. A drop of steroid and then antibiotic is placed. Slit lamp is used to confirm the position, and then the speculum is removed. Visual recovery from LASIK today is very, very fast indeed. The vast majority of patients are able to return to full work the next day, and certainly their vision will be significantly better than driving vision the following day. My outcomes are that to the nearest 0.0001%, 100% of patients will achieve 20/20 vision or better. 20/20 or 6/6 vision is actually not a particularly good outcome, although the industry often quote it and use it for promotion. Most patients, as your optometric readers will know, in their glasses and contact lenses have better than 20/20 vision, and that's what patients want and expect after laser vision correction as well. So we have 95% of our patients achieving 6/5 or 20/16 vision or better, and 85% of our patients will see some letters, if not all the letters, on the 20/12 or 6/4 line of the chart. And that ability to move people from 6/5 to 6/4 vision is, I think, what creates the wow factor, because many of these patients don't achieve that with glasses, and some of them even don't achieve it with contact lenses. So although it's not something that we highlight before, and I would encourage optometrists not to promise this to patients when making referrals, the reality is the majority of patients will tell us that they have better vision afterwards than they did before, even with correction, and that's for them a big bonus. We call it under-promising and over-delivering. So we never tell them before your vision will be better than it was with contact lenses, but that is the reality for many of them. The vision normally improves beyond the first day. So although the first day is the wow moment when patients go from not being able to see to being able to see without glasses and contact lenses, the reality is that for most patients, the vision will continue to improve over about 6 weeks. And the reason for that is that the epithelium essentially remodels to give the cornea a more natural shape. So the laser is programmed and profiled to give the patient the most natural shape possible, but there's an additional biological compensation that is just how we've evolved to anything that changes our corneal shape, which gives patients increased vision. And also the ocular surface normally improves over about 6 weeks, so that's an added benefit. The distance prescription that we treat, we expect to be permanent and stable, so we do not expect regression or significant change with time. The exception being if patients end up with unrelated eye disease. For example, if they develop cataracts when they get older, or significant lens changes, that may cause the vision to change. But much like the refraction often doesn't change once patients are in their 20s significantly, we wouldn't expect the distance component of what we've treated to change. What does change, though, is the need for reading glasses in patients that are yet to become presbyopic or early presbyopes. And I think some of the, again, mythology out there in the community of laser eye surgery wearing off is that people don't counsel patients on the potential eventuality or the inevitability, if you like, of presbyopia. So presbyopia is inevitable. We tell all patients about this, and if they are already in presbyopic age range, we may incorporate this with some form of blended vision treatment. For LASIK, we do advise some preoperative treatment as well as postoperative treatment. The preoperative treatment we advise all patients is to take flaxseed oil as a vitamin pill, 1 gram twice a day, and we advise that from the time of their consultation until surgery, and we let them know we'd like them to continue that for 3 to 6 months afterwards. We find that increases tear production, it improves the composition of lipids on the surface of the eye, reduces evaporative tear dysfunction, and means that they heal more quickly and more reliably. For patients that have significant meibomian gland dysfunction, we may also recommend hot compresses and occasionally even some topical steroid prior to treatment. After treatment, patients always get 1 week of topical antibiotics and topical steroid, and that's to prevent infection and prevent inflammation. And then beyond that, it's just preservative-free artificial tears. We ask them to use it really frequently for the first few weeks, and then they eventually tail down until they no longer need to use it. But we try and educate patients to become environmentally aware. So for patients that spend 9 or 10 hours on a computer screen, we let them know that for the first few weeks they'll be using them much more frequently, because when anyone does any activity where they concentrate more, they tend to blink less and the eyes become more dry. In terms of the follow-up care required, we will always see patients on the day after the procedure, the week after the procedure, the month after the procedure, and then a year after the procedure. And of course we'll see them anytime in between or following the 1 year time point if they feel like they're having any problems. Once it's been 1 year after the procedure, we very much encourage them to go back to the referring optometrist in order for them to continue to have yearly eye checkups. They may need reading glasses if they're presbyopic, and we do respect and encourage that relationship between optometrist and patient, which should be really independent of whether they need glasses for distance or even reading activities as well. They still need to have screening checks for glaucoma, regular eye health checks, and all of the other things that are really important with optometric care, so that's what we do. When we discharge patients back to the referring optometrist, we don't expect them to be doing any specific testing on account of the fact that the patients had laser vision correction. It's just that we're concerned that if patients believe that because they no longer need glasses, they no longer need optometric care, they will no longer have screening checks for glaucoma or any other retinal problems or other issues with their eyes, and they need to keep that relationship going. I often explain to the patient it's much like going to the dentist. You have to go a certain amount of time with regularity to make sure that you don't end up with dental problems that you otherwise might not know about. I think there are a variety of factors that maximise the chance of a patient having an excellent outcome. And they, in no particular order, they are a good relationship between the patient and the consultant surgeon who's going to be doing the operation, so that the surgeon understands what the patient wants and expects, and the patient can communicate what they want and expect to that surgeon. And that relationship has to be good so that essentially surgeon and patient are on the same wavelength with what is being offered, what could be achieved, what the chances are of achieving what needs to be achieved, and what the complications or problems might be. So that's really critical. The surgeon has to be someone who will be happy to exclude patients who are not suitable, so essentially to make a good decision on which patients shouldn't have surgery. The surgeon should also be able to work with the patient in order to pick the best intervention for them. So laser eye surgery or LASIK is not for everyone. There are other options. Depending on their prescription, what they want and what they expect, other things may be better. And if you look at, let's say, unhappy patients, it's always easy with the benefit of hindsight, but you could go back and say, well, actually, if this patient had had, let's say, refractive lens exchange rather than LASIK, or maybe LASIK rather than refractive lens exchange, would they have been happy? So making the right decision to give them the intervention that is most suitable for them is really critical. Once the decision has been made, then perfectly executing the surgery required for that patient is a big determinant of outcome. So even though the technology is also very important, and having access to the right technology and using it in the right way, executing surgery in a predictable, safe and precise fashion is also a big determinant. And the outcomes of individual surgeons do differ on account of that. And then finally, aftercare is really important. So making sure that patients recover and heal in a normal way. If there are any abnormalities or peculiarities, to address those and treat those. And often patients need reassurance, so often the things that bother or worry patients are treatable or not a problem, but they may need to be seen in order to have that dealt with. So it does really start from the time of the consultation until the time that the patient's discharged from care. It's not just the surgery itself, it's a whole process. Wavefront treatments are the most commonly performed, and wavefront treatments can be either wavefront guided or wavefront optimized. Essentially, both of them aim to preserve a natural and normal corneal shape and minimise the induction of any aberrations in the optical system which might reduce a patient's quality of vision. So they're designed to give patients the most natural quality of vision that they can have with the best outcome. In terms of wavefront guided versus wavefront optimized, it is completely laser specific. So it's an exact example of one laser is better, you're better off having a wavefront guided treatment, and another laser you may be better off having a wavefront optimized treatment. Some lasers don't even have the option of both. So you could only do a wavefront guided or you could only do a wavefront optimized. The laser I used, you can do either, but with the laser that I use, a wavefront optimized treatment works better. The difference between wavefront guided and wavefront optimized: wavefront guided treatments, the idea is that you do a wavefront scan preoperatively, and then the laser will specifically change its profile to ensure that any preoperative aberrations are lasered away as part of that laser ablation profile. Part of the problem with that is that the wavefront aberrometer doesn't individually determine what's happening within the cornea now and in the future. What it really does is it's looking at the optical system of the eye, which includes aberrations from the lens, which may change in the future, and also includes ocular surface problems, which may be transient and also may change. So having a really accurate pre or post-operative aberrometry is potentially problematic, and relying heavily on a wavefront guided treatment is something that most of us don't do. There is one particular kind of laser manufacturer where the only way of delivering any kind of wavefront treatment is to have a wavefront guided treatment. So for that laser manufacturer, there's been a lot of emphasis on wavefront guided, but actually where a laser gives you the option of wavefront guided and wavefront optimized, most of us prefer a wavefront optimized treatment because it's more tissue conserving. So essentially less corneal tissue is taken per diopter that we're treating, which makes it essentially less invasive, less dry eye, quicker recovery, etc., etc. The other main way of delivering an eczema treatment is a topography-guided treatment, which essentially means that the laser will be driven based on the shape of the cornea. Again, there are some lasers where a topography-guided treatment will give better outcomes than a wavefront optimized or wavefront-guided treatment, which again is often quite laser-specific. I think where topography-guided treatments really come into their own is where preoperatively the topography is known to be abnormal. So for example, if a patient's had a decentered laser ablation, it's not possible with today's technology, but let's say in the older-fashioned laser technology, or potentially if a patient has ectasia or early keratoconus, if we're combining it with cross-linking and just doing a minimal treatment, we sometimes can correct the irregularity using a topography-guided treatment. The textbooks talk about contact lens wear and the need for refraining from contact lens wear in order to have meaningful corneal measurements. It does vary depending on the kind of lenses that people are wearing. Again, the textbooks will say that for hard or rigid gas permeable lenses, for every 10 years that a patient wore those lenses, they should refrain from wearing those lenses for 1 month prior to the evaluation. So if you're doing, let's say, a cataract surgery evaluation on someone that's been in RGPs for 30 years, you would want them not to wear them for 3 months. I think that that's asking a lot of patients who otherwise are very, very dependent and reliant on them. We normally say we want patients out for 3 weeks. If we do think that there may be some corneal warpage, or where we feel that the corneal measurement is very critical to their outcome, so an example of that would be if we're planning a toric intraocular lens, or we're planning some form of astigmatic treatment, we may repeat the scanning a month later and check that those two are the same and there hasn't been any change. So if we have two measurements a few weeks apart where there's been no change, then we feel we can proceed safely with treatment and planning without them having to refrain from lens wear for so many months. For soft lenses, it's not as important. So we like them to be out for 5 days, ideally a week. But if they can only give us 1 or 2 days out of lenses, we can live with that. We do the safety evaluation. Then prior to surgery, we ask them to be out for a week, and we will recheck the measurements on the day of surgery to check that there's been no change. So if patients have a refractive error that is outside of the range of what we feel we can comfortably and safely treat with laser vision correction, or if there are other things that would exclude a patient from safe laser vision correction, such as reduced tear production and pervasive, untreatable dry eye, thin or irregular corneas, then in those patients we recommend something other than laser vision correction, providing it can be safely done. If patients are under the age of 50, we normally recommend the implantable contact lens, or the ICL, which is a fake intraocular lens. It's a lens that goes in front of the natural lens of the eye, behind the iris or the coloured portion of the eye. It can't be felt by a patient, it can't be seen by others, but essentially requires no corneal surgery, and so it kind of takes the cornea out of the equation when it comes to that particular operation. Having said that, a patient needs to have an anterior chamber depth that is sufficiently deep enough to accommodate that safely within their eye, and high hyperopes often don't. So it tends to be something that we more commonly use for myopes under the age of 50. The reason we have this 50-year-old cutoff is that normally under the age of 50 they're not significantly presbyopic, so the ability to maintain natural accommodation through maintaining the natural lens of their eye gives them more natural range of accommodation, close vision, etc., etc., and it's also less invasive. So the risk of refractive lens exchange or cataract surgery, risks especially in myopes such as retinal detachment, are much, much less with the implantable contact lens. And so patients under the age of 50, if they can't have laser vision correction, providing the anterior chamber is deep enough, we recommend the implantable contact lens. if they're above the age of 50 and they can't have laser vision correction, and that may be because, again, of their refractive error, and in the context of presbyopia that changes a little bit. So an example is a +3 hyperope. If they're 30, it may be absolutely fine to treat them, but if they're 55, we would have to treat the non-dominant eye to almost +5 to drive -1.75 or -2 into that eye, which is above what we normally are comfortable treating. So for patients where refractive error plus the presbyopia consideration is essentially unfavourable for laser vision correction, or again there are other factors such as corneal problems or dry eye, then we will potentially go for refractive lens exchange. An important thing to understand here is that things like significant corneal irregularity might preclude the use of trifocal lenses, for example, because in order for those lenses to work well, the rest of the optical system in the eye has to be normal. So there are other options, there are sometimes intermediate options, there are extended depth of focus options, there are intraocular lenses that use small aperture or pinhole-like optics in order to achieve increased depth of focus, which can overcome some degree of corneal irregularity. That's useful in patients, for example, that have had previous radial keratotomies and have irregular corneas. But essentially, we have to carefully tailor the lens choice to that individual patient, but generally speaking, they should be over the age of 50 and unsuitable for laser vision correction to qualify for refractive lens exchange. So Dilan Beasley, who I'm sure you all know, came to me for a vision correction consultation. Preoperatively, his prescription was more than -7 diopters of myopic sphere in each eye and -3 diopters of myopic astigmatism in each eye. So he was essentially a high myope with high myopic astigmatism. He came, I would say, very well informed and had trialled many different contact lens options to see what would work the best with his demanding optometric work, as well as the research and editing work that he does, and also he's quite active in terms of sport. So he had, I would say, a visually demanding job and pastime, and wanted to explore the best options for himself. It's not something that we have the benefit of in most patients, of having the ability to trial various contact lens options to within 0.25 diopters of what they may actually want. And I think if Ian was anyone else, I probably would have recommended an aim of emmetropia in his dominant eye and then some myopia in his non-dominant eye. What we agreed together, because Ian was so well informed and had trialled various options to know what he wanted and needed, is that we opted for a very low amount of myopia in his dominant eye and a little bit more residual myopia in his non-dominant eye, because he was very, very keen to preserve long-term his unaided intermediate vision, which is where a lot of his optometric work needed to be carried out. We did talk about the implantable contact lens because he's a high myope, and that is one of the indications for the implantable contact lens. In him, my concern was that he would have required a toric implantable contact lens, which, while it works very well for lower amounts of astigmatism, and while it's an excellent option for patients that would be unsuitable for laser vision correction, does have its own considerations. And one of the things that people often don't understand about toric intraocular lens placement is that for every degree that the toric alignment is off the intended axis of placement, patients will lose 3 times that amount in the magnitude of percentage reduction in cylindrical correction. So what that means is we're putting a toric implantable contact lens in. If the lens is 10 degrees away from where we intend it to be, he will lose 30% of the effect of that lens, which would leave him with a residual diopter of uncorrected astigmatic error. And that actually induces coma, which is a higher order aberration, because although that can be corrected on the cornea, you're essentially trying to correct one lens to then refocus the light onto another lens and then allow perfect focus onto the retina. So what you're trying to achieve optically is quite difficult. And just the ink marks alone that we use for lining up these lenses, or any alignment technological equipment that we have to try and make sure that they align in the most perfect way, there's often at least 5 degrees of allowable error in any toric intraocular lens that we use. So laser vision correction doesn't have that degree of error built in within it, so its ability to precisely treat astigmatism is greater, and that's something that we talked about prior to surgery. The risk profile for laser vision correction is also exceptionally low, so there's nothing as safe in terms of the potential risk of an adverse outcome. and that's why we elected for laser vision correction in him. One of the things that we talked about before, and we can show this with his pentacam or corneal tomography images, is that astigmatism or high astigmatism is essentially an abnormality of the cornea. So we can see the bow-type shape of his astigmatism, and what the laser does is essentially it corrects that and obliterates it. So it makes a cornea go from abnormal to normal. Often you think, well, that isn't the case. You're altering the cornea, you're taking a normal cornea and you're changing it, but actually having a 3 diopter discrepancy between the axis of the cornea in one meridian compared to how it is in the other meridian is an abnormal shape. And the ability to correct that with a laser gives significant quality of vision issues, providing we get it right. So many patients will tell us that their quality of vision is significantly better afterwards. They don't have the problem with glasses. If the glasses shift slightly, it's essentially like a misalignment of toric correction, and that does interfere with the vision. If we get it right on the cornea, then we can eliminate astigmatism completely, and patients with high astigmatism are often really happy on account of that.
So tomorrow I'm having LASIK treatment. I'm nervous about going to things like the dentist, let alone contemplating having eye surgery. But at the same time, I'm quite excited by the prospect of being less dependent upon glasses. I've worn glasses now since about the age of 7, and I've thought long and hard about alternatives to glasses and contact lenses since being a late teenager, I guess. Up to this point of reaching presbyopia, those glasses have managed to serve my visual needs. So I'm now in a position where, despite having my glasses on, there's still certain things that I can't manage to do. I think what I'm looking forward to immediately after surgery is being able to see much, much better than I can currently with my glasses off. I'm looking forward to being able to wake up on day 1, hopefully being able to see the alarm clock and just to see the room around me without having to reach for a pair of glasses. Once things have settled down over the first month or 2, then I'm hoping to be in a position where I'm left still a bit myopic. So my target prescription is going to be -1 for my dominant eye and -150 for my non-dominant eye. So I'll still be wearing glasses for quite a lot of things, but planning for the future, I'll then be in a position where I can do lots of near tasks simply by taking my glasses off. I'm also hoping that my vision without glasses will be good enough for lots of other tasks like swimming and running, and just being able to wear sort of fairly normal sunglasses and that sort of thing on the beach. So it's been about an hour since I had my bilateral LASIK treatment. I have to say the process was really straightforward, not painful at all, a little bit weird, but certainly better than having dental treatment. I'd rather have LASIK than have a filling, for example. Vision afterwards feels a little bit like I'm underwater, but already in the past half an hour things have improved. Eyes feel very slightly gritty. I haven't had to reach for the topical anaesthetic that was supplied, so can't really be that bad. After waking up just now, vision is definitely a lot better than it was a couple of hours ago, so that underwater type feeling has largely resolved now. Today feel fine. Didn't sleep all that well, mainly because of the eye shields that I had to wear. They felt a little bit odd. I got up about 5 a.m. because my eyes felt gritty, but put some lubricant in and now they feel fine. I have to say the vision in my right eye is really good, and vision in my left eye is even better. So I'm slightly cross that I didn't have LASIK some years ago based upon these early impressions. My aim was to have -150 in my right eye and -1 in my left. Visual acuity with this top-up refraction in the left eye is 6.5 plus on day 1, and right eye is 6.6 minus-ish. I'm yet to have a full refraction. That will happen next week, but so far it looks like things are on target. I think the most surprising thing for me is that I've got fairly big pupils, but there's been no sense of light sensitivity at all. I haven't needed sunglasses. Watching TV last night even, in the dark, there were no halos around stuff, so that was a real bonus for me. First week has been really plain sailing, I'd say, in terms of vision. It's been really stable all week. Today feels the same as it did on day one after surgery. So left eye is just amazing. Right eye is not far behind, but being a fussy optometrist, it feels like there might be a tiny bit of oblique cyl in that right eye, but I'll find out later on at my refraction at the post-op visit. It's been great being able to go out for a run without glasses on. Drops have all finished now, except for ocular lubricants, which I'm using quite a lot, doing lots of desk work, so putting those in pretty much every hour. But aside from that, feels great. Back home now after going to see the consultant for my 1 week follow-up. Saw the optometrist first and had a refraction. So that -1 in the left eye has been achieved exactly. And the -150 target in the right eye, I've ended up with -125 with a -050 cyl. So really pleased with that. Quality of vision is so much better. So forget the fact that I'm 6'5 plus. I'm also 6'7.5 unaided. But just the image size difference, or just the clarity of everything is just fantastic, especially in the close-up environment. Surgeons reviewed me as well, so topography looks good, slit lamp examination is as expected, so great news all round.
The visual result is far better than I thought it would be, so that's perhaps the biggest surprise. It's hard to put my finger on how or why the vision is better, but just my visual experience just seems so different to how it is, particularly with specs, as you would expect. But even compared to a rigid gas permeable contact lens, the visual quality is different, and I think that must be due to the aberration control. Something else that caught me by surprise was how dry my eyes were after the procedure. So that was fairly brutal actually in those first few weeks. I was using drops maybe 8 times a day. And then I got to about the 6-month stage and things started to improve fairly significantly. And then we hit the winter, and with central heating on, then the dry eye started to bite me again. I'd certainly consider refractive surgery as being a good option for some patients, particularly those that have a similar level of refractive error to me, that are not very tolerant of contact lenses. But I'd also be very careful in counselling them on the impact of presbyopia. So I'd really want patients to strongly consider being left undercorrected, because the benefits for me have just been fantastic. I think the 2 main things that I've learnt is not to downplay the potential for dry eye. Certainly in my experience, it wouldn't put me off, but I would hammer that point home to patients that you will have to be meticulous about your dry eye management for several months after the procedure. And just the quality of vision is just, as I said earlier, it's just fantastic. So I'm really pleased that I got it done.
Ian refracted to within 0.25 diopters of exactly what we intended. He had the distance vision and the reading vision that he wanted afterwards and was really happy with the outcome.